Hello, everyone. My name is Daniel Gonzalez, and I would be presenting a presentation on a uh, myopathy of diabetic versus alcoholic cardiomyopathy. And let's go right ahead with the question: what is a myopathy? Well, in this case, we will talk about cardiomyopathy and what that is. So. Uh, You could see here I incorporated the images of three different hearts, one being the normal healthy heart, and two being two different kinds of myopathies. And I could just start off with the middle one. And I mean, the middle is more of the common one we think of or see when we think of myopathy or cardiomyopathy, and it's the hypertrophic cardiomyopathy. And yeah, like I said, this is one that we commonly see the most, where the ventricle, left ventricle, is hypertrophic or hypertrophied, and this doesn't only occur in the left; it also occurs on the right, but it's more common on the left, and or we've seen it more on the left, and the hypertrophy is pretty much the cells being remodeled and being enlarged due to, um, for example, due to, let's say, high systolic blood pressure or high resistance that the heart has to pump or use its muscles to try to force that blood out. That it throughout time, that constant high pressure, it would the cells would remodel and change. Um, the third image or the third heart would be the opposite, so it would be more of a dilation issue or dilation of the ventricle. And in this case, the cells, I would explain later on how this occurs in my presentation. Later, the cells, they would die out or they would thin out. Not necessarily the cells themselves would thin out, but the amount of cells would be less, causing this thinner wall and this dilation of the ventricle. And this is mainly a loading issue, um, not necessarily I would say more of a loading issue and not a uh, unloading, well, not a systolic removal of the blood. So these two are different kinds of cardiomyopathies, and myopathy pretty much means disease of the muscle. In this case, the heart muscle is disease, or there's a disease happening, occurring in this muscle that's causing this remodeling and this change that is preventing the heart to do its proper function. And I incorporated this other image here because I always say this in all my presentations, and I will keep saying it because you never know who will be watching. But just because you have the more muscle does not mean that it's better because more muscle, stronger, more contractile force. Not necessarily. That's why I incorporated this image here, because you could see that yes, you do have a lot more muscle, but you have a lot less space to try to for your blood to be in there, and less space for that heart to actually contract and to recoil back or to fill up its ventricle. So having more muscle is not necessarily the best, because here you're decreasing your amount of blood you could carry in that ventricle. So this is a quick summary of what myopathy is, or how it what it pretty much means, and the two different kinds of myopathies that we see. It's a hypertrophic cardiomyopathy and a dilated ventricle cardiomyopathy. Um, and how can a cardiomyopathy present? Well, we do EKGs or ECGs, some people say, and this shows the electrical conductivity of the heart, and we could see certain things that would tell us the heart, something's occurring with the heart, and these can include, bundle branch blocks, um, also a ischemias, or uh, damage or infarctions. In this ECG here, you can see that the person or whoever did this ECG circled leads 1, AVL, V5, V6, and V4, and they circled the ST segment, and this is showing pretty much how you or what you would see in a myopathy or cardiomyopathy patient and or expect to see. So in this case, we have the ST depression. So the ST depression, what we know about that is that the depression shows ischemia of the heart. Well, is the whole heart? No. Well, we know that lead 1, AVL, V5, and V6, these are a lateral view of the heart. So this is showing the lateral wall of the heart. And V4, along with V3, these are it's the anterior wall of the heart. But they didn't circle V3. I don't know for what reason. Maybe there might be a square off that it's will not be considered as a depression. It seems, well, it seems depressed, but maybe not as significant as V4. As you can see, it seems to be like a box and a half. But yeah, so the depression will be the ischemia. And if we were to see, what would happen if we were to see the opposite? Well, the opposite would be elevation, and the elevation of the SC segment will be damage. So it will be, instead of ischemia, it will be damage to that wall. So that's how we could see myopathies with the EKG. Another way we can see myopathies is with an X-ray, and you could see it's very obvious that the heart is extremely large. So this is another way. Some people have to be a little bit careful because positioning is also key in X-ray. Positioning always has to be appropriate to appropriately interpret the X-ray and not misdiagnose. Well, then again, you would use other diagnosing tools too, not just one. But in this case, we could see that in the cardiomyopathy, let's say in hypertrophic left ventricle, you could see that it's very enlarged. So, but in this case, the heart is very enlarged, and I may be wrong, but I also believe that, and also in a dilated heart, you would see the same thing to an enlarged heart. And we usually see this when the heart is overloaded with fluid or hypertrophy. So this is another way we could see cardiomyopathies within a patient. So we saw how ECGs would show and X-ray would also show. So you go ahead and start and see the alcoholic damage that is done to the heart, or the alcohol myopathy aspect of this presentation. So what I found out that alcohol causes inflammation, and it can even cause coronary vasospasms. It could interfere with the actual structures of the vessels and also membrane structure. So you can see later on down there I have that listed as well. It could also cause free radical damage to the heart wall, which means the ROS, the radical oxygen species that are out. It can also inhibit protein synthesis, and the way it does this inhibition is there's a study that we have the free fatty acid ethyl esters, and these arise because these are a result of the metabolism of ethanol. So there's more of the fatty acid ethanol esters because they're there to metabolize ethanol. But you can see, I want to skip a little forward. You can see right there in the last bullet point on the left hand, it's fatty acid ester accumulation, and that could be bad for the reason that when there's the fatty acid ethyl esters out and about because they're going to metabolize the ethanol, but there's a genetic defect in the synthesis of the fatty acid esters. So when the fatty acids are out, they can be synthesized to decrease. So now you have this accumulation of the fatty acid esters, and now the fatty esters can further impair the mitochondrial phosphorylation, and also this could incorporate into the inhibition of the protein synthesis. And also, again, like I said, it damages the mitochondria, so it impairs the mitochondrial phosphorylation. There's also a study on how the alcohol decreases the protein synthesis, excuse me, because of this way, and also because when there's an alcohol or ethanol increase, there's also the acetaldehyde because you don't have the ethyl dehydrogenase, I believe, to remove the acetaldehyde as well. So that will be impaired, or the enzyme to remove the acetaldehyde will be impaired as well, and you would have more acetaldehyde now um, roaming around, and that increases oxidative stress, which will go back into the free radical oxygen damage to the heart and inflammatory response. So each of these things, have they're all related in some point, and the alcoholic damage also increases coronary vasospasm, like I said. With the release of troponin T also, and they each have a relationship with each other. Here it's an image that I incorporated how the alcoholic damage could lead to the the cardiomyopathy, and how it's listed here. So we could start with the image on the left, how the alcohol consumption over 5 years, you could see that some of the cells start to die out or program themselves to die out for the reason that there's more ROS within them, so they self program themselves to die. There's more stress, and it decreases the synthesis of the degradation of the contractile proteins. Like I said, it inhibits protein synthesis. So this inhibition of the protein synthesis could inhibit those proteins needed for the contractile of the heart. It also decreases the myofilament of calcium. It also, remember how I said it damages the mitochondria, so the intrinsic myocyte dysfunction due to mitochondrial and sarcoplasmic dysfunction. So it's like a chain reaction, and once this occurs, you start to see the cell dropout, meaning the cells start to die out. So the amount of cells you have is now being decreased or starting to fall down, and this leads to a weak contractility of the heart because of the dying out cells. And I didn't mention this, but I think what I found out about the alcoholic damage is that the myopathy it presents as more of a diastolic, or sorry, not diastolic, but a dilation issue compared to a hypertrophic issue. So with the alcoholic damage, I see more of a dilation issue. Not that it doesn't have any hypertrophic components, but it's more of a diastolic, what I found out. So with that dropout of myocytes, having less cells, that would cause your heart your cardiac output to decrease, for the fact that your strength of pushing that blood out is a lot less. Now the thing is that would cause a dilation because you have an increase in the end diastolic volume, and to compensate for that decrease of cardiac output, your myocytes will become hypertrophic. So you see how it's kind of not contraindicated, but a little bit confusing. So because of your cells dying out, you have that thinner wall, so it's your ventricle starts to dilate. But the cells that are left over, those will have to compensate for that reason, or for the reason that the other cells have died out or been dropped out, and the ventricle is dilated. So those cells are still there, have to compensate, and they become hypertrophic, or they become hypertrophic. So the hypertrophy of normal myocytes are there because they have to compensate for the of the myocytes. And the diagram shows that if you continue to drink after those 15 years, then you will have more progressive left ventricle dilation and wall thinning. And also, you will have the signs and symptoms of heart failure. You start to show more signs and symptoms. And like we talked about in Gongo's class, that sometimes you can have a disease and a time where you start to show symptoms or and signs, the progression of the disease has been already towards the end stage, or it has already progressed so much that the window for intervention is very minimal. And in this case, this is kind of how that's kind of what that represents. So if you keep drinking more, maybe within the 5 years or first 10 years, you may not see the symptoms because they're not they're not showing, but you still have this remodeling of the heart and this damage to the heart that maybe by the time you start seeing signs and symptoms, it may be too late to try to reverse or try to do some minimal interventions. And also, this would also cause some activation of the neurohormonal system. And this other picture that I incorporated to the right hand just pretty much shows what would increase and decrease and what would change with the consumption of alcohol. And it's kind of what I explained already, so there's no reason for me to further on and go ahead and describe those. But the green box pretty much shows the end product, sort of say the clinical consequences of alcohol effects on the cardiopulmonary system would be a dilated cardiomyopathy. We already talked about why. Hypertension, cardiac arrhythmias, and the risk for pneumonia and ARDS. And for the cardiac arrhythmias, I find it kind of funny because we talked about in class with Tracy that that I found out that the left ventricle is very sensitive. That if it were to be touched, or it's very sensitive that it could easily go into arrhythmias for the fact, or yeah, not arrhythmias but dysrhythmias, because it's so sensitive that if you touch it, it could go into that dysrhythmia. Now, what are signs and symptoms that a patient with a alcoholic, cardiomyopathy would show? And these symptoms are, the common symptoms that we see in, heart failure patients. And it will be, the enlarged heart for the fact that you have that fluid overload. Murmurs, and some patients will present with murmurs because you have the remodeling of the heart, and sometimes even the tendons that hold the valves. Congestion, that's a obvious one you would think, especially with heart fluid overload. JVD, because you have that fluid backing up and just going into the jugular vein. And edema in the extremities, the lower extremities, because just that fluid backing up and starts basing into your lower extremities. Shortness of breath will be a common one. The fluid's going into your lungs. Fatigue, weakness, irregular and rapid pulse, and this would go back to the whole ventricle issue or sensitivity of how sensitive it is. Cough, you'll have some cough, and dizziness or fainting because you won't have that appropriate blood pressure that your brain needs to perfuse your brain accordingly. What are some treatments that you could take for this issue? Well, medications include beta blockers, ACE inhibitors, and diuretics, and these are all not to treat the cause of the heart effect, but to treat the issues that you're living with the heart defect. And beta blockers, ACE inhibitors, to cause vasodilation and removal of the fluid along with the diuretics. You want to prevent any further fluid overload, low sodium diet, and fluid restriction. And key component also is to talk with the patient to try to prevent any further drinking or to cease that alcohol abuse or alcohol intake. And in some cases, yeah, or more invasive cases, there could be some interventions where, let's say uh, your heart is damaged to the point that you would require a pacemaker because your SA node has been damaged, or you need to defibrillate yourself because you're having these AFibs or dysrhythmias, that you would incorporate an implantable defibrillator or ICD to defibrillate whenever the patient's heart rate goes out of whack. And in some cases, and these are uh, um, more of a severe case, kind of like a last minute thing, um, the possible heart transplant um, could be an option. So we could go ahead and talk about diabetic damage to the heart and how that causes the cardiac myopathy. Well, this seems like a short list, but is a pretty mouthful on knowing how these of these six things affect it. There's other things, other components too. There's a lot more things that diabetic, uh, um, how diabetic incorporates to the damage of the cardiomyopathy. But here are a few that I incorporated. With hyperglycemia, we could see, for example, one of the principal abnormalities is that it's an impaired coronary vasodilation, the capacity to increase the production of the age, and age presents or represents stands for advanced glycation end products, and so this is impaired. Well, well, not the age that is impaired, but the vasodilation is impaired, secondary to the increase of age. Hope that make kind of hope that I make sense with that. Not that I hope I didn't confuse you all with that. Also, with a hyperglycemia, we see that there's an increase in the ROS, um, and that occurs because with hyperglycemia, you're kind of overworking the mitochondria to compensate for that, the hyperglycememia, and that overworking stresses out the mitochondria that will release these radical oxygen species. Just like what I talked about in my atherosclerosis video, and so hyperglycemia causes ROS, and that's we know that increased ROS could cause damage. And this also affects contractility of the heart. So we know that hyperglycemia could cause all these things. Many people don't know that. I didn't know that myself, but it happens. Fatty acids. So fatty acids. So when the heart, so there's this mechanism so that when the heart is ischemic, we have, or normally when the heart is ischemic, or there are higher pressures in the heart, the heart uses the ATP production um, to use as to predominant glucose oxidation. So they would use this as energy when the heart's ischemic. They would use ATP, for energy. But in the diabetic population, they don't have this mechanism, and only 10% of the myocardial energy will come from glucose in the diabetic population. So they won't have the ATP production to a prominent glucose oxidation. So the fatty acids. So this is mainly due to depleted. The reason why the diabetic patients don't have this is because it's mainly due to a depleted glucose transport proteins 1 and 4, and this results in a more pronounced beta oxidation of FFAs, and elevated FFAs are associated with insulin resistance and calcium transport protein dysfunction. So these both leading to impaired cardiac function. The increased fatty acids are also associated with the activation of proliferation activated receptor A, or PAR, PPAR alpha to be short. And this is suspected to promote mitochondrial uncoupling of oxidative phosphorylation. So this mechanism that reduces the myocardial high energy reserves and contractile dysfunction. So increased intracellular FFAs may directly lead to apoptosis. Another way that diabetic damages the heart is through protein kinase C. And what protein kinase C is an intracellular signaling molecule, and is activated in diabetes and can lead to endothelial dysfunction by reducing the concentration of nitric oxide and increasing the ROS production. Also, the protein kinase C can also enhance the leukocyte adhesion, and which increases albumin permeability and impair fibrinolysis. So this, you can see that we could possibly get more fibrosis with this protein kinase C. RAS, which stands for the renin-angiotensin-aldosterone system. Um, when and this renin-angiotensin-aldosterone system is it's a like a response to, well, it's activated by the myocardial stretching of the stretching of the myocardial cells and to with their stretch receptors. So the RAS or RAS would be activated because of the stretching. But in patients who are diabetic, there will be an upregulation of RAS, and this occurs even though there's going to be there's a small change in the myocardial loading. So even though there's small stretching, there's an upregulation of RAS, and it has been suggested that the aldosterone and glucose can cause cardiac fibrosis through the stimulation of the myofibroblast growth in patients with dysregulated RAS. So this especially with concomitant hyperglycemia. So this is bad, and we see this in the diabetic population. The next one will be hypoxia inducible factor 1. And I found this one pretty interesting. And so for diabetic patients, this response, or what this response is that when the heart becomes hypoxic, there's this angiogenesis of vasculature and of collateral blood flow that would respond to this, and allow the blood to properly flow because of the hypoxia. But in diabetic patients, this angiogenic response to the myocardial schema is blunted. So it's blunted. So, and the reason why it's blunted is because it's secondary to reduced VEGF, and its receptors VEGF R1 and VEGF R2. So this is reduced because the VEGF is also reduced about 40 to 70%. And it also causes endothelial dysfunction, and hyperglycemia results, like I said, the ROS. So it also results in impairment of endothelial cell nitric oxide production. So it decreases the nitric oxide production, increases production of vasoconstriction prostaglandins. It also increases the glycated proteins. It also increases endothelium adhesion molecules and the vasculature or vascular growth factors, which cumulatively enhance vasomotor tone and vascular permeability, growth, and remodeling. So it changes all that. So it remodels the cells. It causes them to be more permeable, and hyperglycemia can also cause or also enhances the endothelial cell matrix production, which can contribute to basement membrane thickening. So this is, like I said, it's a mouthful. There's a lot more things that could cause damage to the heart with diabetes. And my next slide here is just showing a image of pretty much what I talked about. So we could see that I mentioned the PARB. PARB is there, so it's the proliferation activated receptor alpha, uh, not PAR alpha, and that's what we saw that it's associated with the fatty acids, and you can see that with diabetes you have an increase of free fatty acids and triglycerides, and then the diagram is showing with this increase of free fatty acids upregulates PAR signaling, and that increase in PAR signaling increases the F8 oxidation genes, which increases oxidation, which release ROS, and this could cause lipotoxicity. Um, wow, what I also mentioned? I also mentioned the age. You could see in the left lower area, right above the second ROS, you can see age is upregulated too, which could cause the fibrosis. And the mitochondrial uncoupling, increased mitochondrial uncoupling causes that. It's a like I mentioned in the other slide that it causes mitochondrial uncoupling that could also cause damage to the cardiac dysfunction, and the hyperglycemia, increased hyperglycemia. You see that in patients, and like I said, that increases the ROS, and all these factors play a role in the cardiac dysfunction, which then in result is a diabetic cardiomyopathy because it's caused by the diabetes. And it's funny how all these things play a role in the disease of the mile or of the heart muscles, and yeah, it's pretty interesting. Here's another image that I incorporated too, and how diabetes causes all the uh, different abnormalities or different um, myopathies or diseases, and the endothelial dysfunction. It says that diabetes causes endothelial dysfunction. How we talked about in the previous slides, coronary artery disease, because that increase in the ROS could, we know that whole trend of the increased ROS, the oxidized LDLs with the macrophage and foam cell, and there you go. Coronary artery disease, the atherosclerosis, myocardial fibrosis, I believe that so-called too. So this is a diagram that shows that. I'm going ahead and signs and symptoms. The signs and symptoms are almost pretty much all the same compared to the alcoholic cardiac myopathy, uh, large heart, and the only difference that I realized, not that there actually is that difference, that the diabetic cardiac myopathy has, is not just that it does only have the atherosclerosis compared to um, the alcoholic one, but that's the what I noticed the difference. Maybe there is a causation of atherosclerosis in the alcoholic, but maybe further down, but not that I saw. Congestion, JVD, edema, simply the same ones as previously. And like I said, treatments. The treatments in this one would be similar to the alcoholic cardiac myopathy with the ACE inhibitors and beta blockers, but there will be a different intervention, as in their more of a chronic disease. So with the first one, it's more of the alcoholic drinking, more of the lifestyle. This one's also a lifestyle, so you would want to have the patient control their glucose intake by watching their diet, also their insulin management. That way, you gotta watch both your glucose intake and your your insulin within your body. And you kind of want to balance that out. Also balance what you eat and how you not how you work out, but how you if you work out, make sure you keep a good balanced lifestyle. So it's funny because these two, diseases, um, there is no, well, at the point we start seeing signs and symptoms, is not that these treatments are to reverse what you have, but to prevent your disease of getting worse or to getting worse. So these are more of like, okay, preventative treatments of later on in the future. So you want to control your high blood pressure. You want to control your vasospasms. Um, you want to control the blood pressure and everything. I think I repeated myself, but yeah, you want to control those things and prevent the disease from getting worse by watching your lifestyle. And I've noticed that that's what I've noticed from the two. And this is the slide represents the information or the works cited of where I found my information. And this slide will conclude my presentation. And I hope you guys found it informative and you guys enjoyed it. And I hope that I did not bore you. So thank you again for listening. And I hope we continue to do more. Thank you.